Let me start by talking about federal opportunities that have been established by the Affordable Care Act. Medicare and Medicaid, we've got a bunch of pilot programs and demonstrations. I'm going to come back and talk at the end in my sort of final comments about how to get involved in these, because I realize that most of you in the audience aren't academicians. You're not like me. You're not applying for federal grants. You're not applying for state grants. But nevertheless, you're running companies. There are opportunities out there as a result of the funding opportunities that I'm going to be talking about during my brief comments for you to partner with academicians, to partner with healthcare delivery system to go after some of these funding sources. So I'm just going to talk a little bit about what was authorized by the Affordable Care Act. You see that we've got the Innovation Center, CMMI, and this has been a true source of great funding for testing new payment models and funding innovation grants. Of the 26 projects that were initially funded in the first year, 7 of them involved telemedicine. Accountable care organizations, I'm going to talk more about this. This is really, in some sense, a lot of expectation in the Affordable Care Act that ACOs are going to be the way that we achieve innovation in the future and achieve cost savings. And I'll talk a little bit more about those in a minute. Medical homes for the chronically ill and Medicaid. We've got health home demonstrations. I'm personally involved in my center. I'm the director of the Center for Health Policy Research at UCLA. We're working with the state of California to do an evaluation of the proposed demonstration project. Now the state is going to go after funding for health homes, this ACA funding, but they're still finalizing actually what the demonstration is going to look like, and we're working with them to craft an evaluation of that. The Independence at Home medical practice demonstration program increases, this provides increases in home health and integration using telehealth. And then state waivers to promote integration of services for dual eligibles. That's the Medicaid and Medicare population. As probably everybody in this audience knows, the dually eligible are some of the most expensive publicly insured beneficiaries in the Medicare and Medicaid programs. And so finding innovative ways of providing care, coordinating care to this population has potential to produce great savings to the federal government and to state governments. Let me talk a little bit, as I said, about the ACOs. Technical difficulties. I have to say that I really admired Mark McClellan, the way that he handled the fact that about half of his slides, as any speaker knows, that's sort of your worst fear, is that suddenly your slides don't work. As a professor, I go into class, I just assume that all of that's going to work just fine. And when it doesn't, it's a little difficult to give a talk when I'm saying, well, this slide, imagine this slide here. But Mark did a great job. So the ACO, what are the options? I'm not going to go through these in any detail other than to say that there are now 4 options under the ACO program. The initial was the Pioneer ACO model, and of course this program is no longer available, and it's actually been shrinking in the last few years. But the core of the ACO program is the Medicare Shared Savings Program, MSSP. But CMS has rolled out, in addition, the Advanced Payment ACO model and the ACO Investment model. And the key thing to remember about these last 2 programs is that they sort of expand on the MSSP program by providing fixed payments. Basically, CMS is acknowledging that particularly in rural and underserved areas, in order to get physicians, medical groups to invest in the technology necessary to be a successful ACO, CMS is going to have to provide some initial investment to help sort of bring medical practices and doctors along. And so they're making this sort of initial investment, capital investment available through these programs. In this slide, I just want to remind everybody that ACOs, one of the key requirements of successful ACOs are reporting quality measures. There are 33 quality measures that are required for to be reported to CMS. They fall into four broad categories. Patient caregiver experience, there are 7 measures. Care coordination and patient safety, in which there are 6. Preventive health measures, where there are 8. And then at-risk populations, where there are 12 measures dealing with 5 chronic conditions. And these are the conditions that have been talked about in some of the other earlier presentations. Not surprising that these would be on the list. But the point that I want to emphasize is that this quality measurement and the fact that we've got patient satisfaction, care coordination, creates opportunities for telemedicine and telehealth. In order for ACOs to perform well on these measures, it creates a natural incentive for the adoption of these new technologies so that the providers can perform well on these quality measures, because their payment is ultimately going to be tied to how they perform on these measures. Now, the ACA has also created a new national focus on quality and some other measures. So there's value-based purchasing in the Medicare program, which allows Medicare to compensate hospitals for meeting quality performance measures, and there is the hospital readmission prevention program and value-based purchasing. Mark talked a little bit about value-based purchasing for hospitals in his talk earlier today. So these are new initiatives under the Medicare program that are withholding a certain amount of payments to hospitals and then redistributing that money based on performance. We've got the Patient-Centered Outcomes Research Institute, PCORI. And PCORI is probably one of the most significant pieces of the Affordable Care Act, outside of the insurance subsidies and the exchanges, because it creates a new federal mechanism for sponsoring research that is patient-centered. PCORI is extremely well funded. The process of reviewing proposals includes consumer and patient input, and it provides, again, I think, another mechanism and an opportunity to support innovative programs in telemedicine and telehealth. There's the National Quality Strategy, which was released, the report, in 2011, with a focus on better care, healthier people and communities, and affordable care. And then the Community-Based Collaborative Care Network, which provides for coordination and integration of primary care, hospitals, and other community providers. So the point that I want to emphasize is that the Affordable Care Act has a number of mechanisms and a focus on quality and explicitly on innovation that I think is very supportive for the growth of telemedicine and telehealth. Let me talk a little bit about other federal efforts and state efforts. And so one of the developments is the Office for the Advancement of Telehealth. We were talking earlier today that in healthcare there are numerous acronyms, and this is one of the best that I've seen recently. I'm sure that somebody sat down and thought about this one. But OAT is part of the Federal Office of Rural Health Policy, which is part of HRSA, the Health Resources and Services Administration. And the office funds 6 programs to promote telehealth in rural areas. And I'm not going to read the 6. But the fact is that these are funding sources, again, getting back to the point that I was making earlier, that this provides federal funding for innovation, specifically in rural areas, and for the adoption of telemedicine and telehealth. I wanted to speak for just a minute about California's Medi-Cal coverage for telehealth. One of the issues that's come up in a couple of this morning's talks is, where is the incentive to adopt this these new services and what are we doing with regard to payments. And so in preparing for my presentation, I was pleased to discover that California's Medi-Cal program, which is our Medicaid program, actually has adopted payment for a series of telehealth services. So selected E&M services related to visits and consultation are paid. Selected psychiatric examination and therapeutic services. The state is paying for store and forward of teledermatology, also store and forward of teleophthalmology, transmission costs of up to 90 minutes per patient per day, and originating site facility fees. So the point is that the state, for its most vulnerable population, the Medi-Cal eligible population, is paying for these services now. Now, what are other states doing? I didn't have time to do a comprehensive survey, but as part of the program that I was talking about on the previous slide, the Office for the Advancement of Telemedicine or Telehealth, they have funded the Center for Connected Health Policy, CCHP, which is based in California. This center is a national telehealth policy telehealth policy resource center, sorry. It's funded by the HRSA program, and this is their website. So for those of you who are interested in knowing what's going on at the state level in terms of payment policy under each state's Medicaid program, this center is compiling that information, has an interactive website. You can click on the map and find out what's going on in the state that you're interested in. But this is one of the programs that's being funded by the Office for the Advancement of Telehealth. And the website is, I've got down in the lower left-hand corner. The other mechanism to fund innovation in state Medicaid programs is what's known as the 1115 waiver process. And I've got the quote here, so I won't bother reading it, but basically 1115 waivers are a mechanism for the federal government to fund innovation in Medicaid programs around the country. California's been particularly aggressive and successful in pursuing 1115 waivers over the year. It just recently got approval for its third consecutive 1115 waiver, which is called Medi-Cal 2020. Other states pursue the 1115 waiver process as well. But one of the provisions in the California waiver application and now in the approved waiver is what's known as the Global Payment Program for Safety Net Hospitals. And you can see at the bottom of the slide that one of the goals of the GPP, the Global Payment Program, is to encourage public hospital systems to provide greater primary and preventive services, as well as alternative modalities such as phone visits, group visits, telemedicine, and other electronic consultations. So this is a program, this Global Payment Program, which is basically going to provide safety net hospitals with a global budget, is going to provide a very strong incentive for safety net hospitals in the state of California to adopt these alternative methods in order to reach out to the most vulnerable populations. Finally, I'm going to wrap up, and I mentioned to Bruce that I was going to wrap up my comments early. Just some final thoughts on telehealth and federal and state efforts. It's quite clear that the federal and state policies are evolving rapidly to encourage telehealth services, particularly for vulnerable populations. And we talk about the Medi-Cal program in California, the Medicaid program in states throughout the country. We're talking about the most vulnerable. Medicaid payment for telehealth services is a significant incentive for promoting the use of such services. And value-based purchasing, including bundle payments, should encourage the use of telehealth services in the future. because they can increase access at a lower unit cost while improving quality. And I think Mark's presentation earlier summarized this really effectively, that a lot of innovations in healthcare tend to be cost increasing, if only because they expand access for unmet healthcare need. But I think telehealth and telemedicine actually provide that rare opportunity in healthcare for us to actually lower cost, not just the cost per unit, but actual overall expenditures because of improved efficiency and improved coordination of care. Nevertheless, progress remains slow. And I don't mean to be pessimistic, but the fact is in preparing for my presentation and looking at what's going on, for example, with ACOs around the country. So we've got over 400 ACOs under the Medicare Shared Savings Program. There are hundreds of additional ACOs that have grown around the country, more than 100 in California alone, that are serving privately insured patients. But at least one study that I was able to find in preparation for today's talk suggests that more than 80% of ACOs still are not adopting telehealth or telemedicine. And the article did not go into great detail about all of the remaining barriers, but the fact is that despite all of the potential advantages, despite the fact that the federal government and state governments are trying to encourage the adoption of these kinds of innovations, we're still progressing slowly. So there's still room for lots of improvement, and I think that that means that for people in the room, there's still lots of opportunities to take advantage of these government efforts to increase efficiency and increase adoption of these new technologies.